is a zygomatic salivary mucocoele. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So some interesting anatomy here. We've got a huge maxillary vein, which is sitting right here. And we've got facial nerve, which is branching right here onto the lower and upper eyelids. It's called the palpebral nerve at this point. And so I'm going to have to remove a segment of the zygomatic arch in order to access the orbital space so that we can get access to that zygomatic salivary gland. So I'm making my incision kind of parallel to the zygomatic arch. And being careful for my palpebral nerve, which is going to be right up here. And rostrally, being careful for my maxillary vein, which is huge and sitting right here. So I can certainly sacrifice it if we need to, but I don't want to inadvertently cut it because we'll get not dangerous blood loss, but enough to be pretty annoying. I'm just extending my incision rostrally there, and I'll get my Gelpi retractors in here. Yes? Is my head in the way of the...
No, it looks good.
Okay. Have to be careful with the globe as well, that we don't inadvertently put a Gelpi into it.
Your head in the camera.
Thank you.
Until when you go near the palpebral nerve, you get a twitch.
Yeah, we're getting a bit light here. I'll move the camera forward. Should reduce the likelihood that my head will get in the way. Alright, so we can feel that zygomatic arch right there. It's still a little bit light, and as always, it's a battle between blood pressure and anesthetic depth. This dog presented with exophthalmos. And aspiration revealed saliva. I just did an MRI on it and found a really large mass that was encircling the ramus of the mandible, and I thought, oh, is this a tumor that's really invasive? And I aspirated it, and it just got all saliva out of that, and so it's just saliva that's accumulated all around the mandible. So this is masseter muscle sitting right here. So there's a question, when the patient gets light, what do we notice? And we just see an increase in respiratory rate usually, and sometimes blood pressure will increase. Sometimes we'll see blinking or other signs of movement. And And there is a depth of anesthesia that you'd guarantee that they weren't going to move, but you'd be concerned that you'd run into cardiovascular issues. Just like there is a dose of chemotherapy that will kill all the cancer. However, you might also kill the patient at the same time. Can I get small Homans, please? Thank you. And a periosteal elevator, please. So we're live streaming this, Kevin, just so you know. You might see a palpebral reflex as well. So that's my zygomatic arch right there. That's a bit of periorbital fat. We'll get into the zygomatic ligament right back there as well. Are you happy, Georgie, or are you...
I'm happy. I'm just completely changed my tack, and so I'm just rebalancing.
Right. So we do have a specialist anesthesiologist scrubbed in on that, or not scrubbed in the room, doing our anesthetics, which is really lovely. She also happens to be a lovely person, old Georgie.
He has to say that while we're in theatre, though. Captive audience.
Otherwise, she might just walk out.
We have a question about the anaesthetic protocol.
Hold on to that. What is the question?
The question is, what was the anaesthetic protocol? Do you have exaggerated palpebral because of nerve stimulation versus anaesthetic depth? So the first part of that, we have used methadone and aceclomazine to sedate this patient prior to induction with propofol IV to effect, and then maintenance with isoflurane in oxygen. And now I've just added to that some alpha-2 agonist, a low dose of medetomidine to balance out the isoflurane. And in terms of the palpebral, is there some direct stimulation, or is it all just depth related? Given that the diathermy is running quite close to those facial nerves, there probably is a little bit of contribution, but when we had that flickering palpebral reflex when diathermy was applied, we also had increased heart rate.
Should be all the way through.
And that increased heart rate would suggest that it was at least partly anaesthetic depth, and that makes sense. We did do a nerve block in this dog, but the location of some of the skin manipulation is beyond the reach of that block. And then the dog has also had paracetamol and meloxicam as part of its multimodal analgesia protocol to offset the MAC.
Can you please grab that other microphone that's in that little black box?
Oh, yeah.
Yeah, and clip that on Georgie's face.
I was watching the green go up.
So Georgie is getting mic'd up now. Georgie likes to talk.
Georgie does like to. Do I need to repeat what I said? Did people hear it? Was I loud enough beforehand?
I think you're probably okay. All right, so now we'll come in and get the other side of the zygomatic arch. And this is right adjacent to the zygomatic ligament. Can we get some saline, please? So that's just attached by the zygomatic ligament up here. Cutting away that periorbital kind of fascia. And these do tend to bleed a little bit, but not dangerous. Annoying bleeding, but not dangerous bleeding.
We have a question here about the loco-regional technique, and I did a left infraorbital nerve block using bupivacaine, and my aim was to flood the canal to get caudal spread towards the maxillary nerve root in the pterygoid fossa, because the anatomy was disrupted, more caudal. So we expect a slightly more patchy block with that, because I'm kind of having a bit of a hope and a prayer that it's going exactly where I really want it.
So that's all just periorbital fat. That may be getting into a bit of the salivary gland. That's the mucocoele sitting right there. And this mucocoele is absolutely huge. I hadn't done one of these in a while, and so I looked online, found one of my old videos of one of the surgeries that I had done previously, and watched it to review the anatomy. That's always handy. So what we're going to do is I'm going to perforate that, and this is going to be pretty exciting. We're going to get a lot of saliva here. How good is that? This infraorbital nerve sitting right there. Just trying to find that salivary gland now. And you've got this venous plexus that's inside the orbit that you have to be aware of as well. So this dog just had exophthalmos and went to an ophthalmologist who did an aspirate and found just saliva. here, so I will just pack that off for a minute, see if there are any questions. Clean out our suction.
Liz Spencer has asked, is this a common location for a mucocoele, having only seen submans and sublinguals before?
So this is not a common location for a mucocoele. I've only seen probably half a dozen in my career, compared to probably 40 or 50.
I think this is my first one, you know, Charles.
Right.
Yeah.
So this is the mucocoele sac. And we don't have to remove the whole sac because it's not a true cyst, but we do need to remove all of that salivary gland tissue. Go back to the pool. Can I get a bigger Yankauer tip, please? Bigger Yankauer? No, bigger than that. That one there, I think, is the one, yeah.
Charles, is having a mucocoele in one gland a predisposing factor for others?
Not at all. So there's, not sure if that, yeah, so there is no predisposition for this dog getting more mucocoeles. Certainly not that I'm aware of. So that's the medial aspect of the orbit there. Be a bit careful with that, just because the globe is going to be right there, Jacob. So that's the optic stalk up in here. So that's where the optic nerve and all of the retrobulbar muscles are going to be. And now I'm just looking around to see if there's anything else that looks like salivary gland tissue. So I'm used to taking a bit more out than we have. Apologize if my head's in the way. And as I often say, if only one of us can see, it probably should be me.
Most of the time there's a view. It's only every now and then that you're in the way.
In the section, please, for me. I think that's about all we're going to get out here.
Are you able to answer a question, Charles?
Yeah.
We have a question. What is your go-to approach for finding a bleeder?
Finding a bleeder, usually we pack it off and go ahead and flush. And hopefully that's going to, like if you can't visualize it directly, we'll pack it off for about 5 minutes and see if that slows it down enough that we'll be able to see it. If not, you can just flood the area with saline and get a better idea of where the leaking is, the bleeding is coming from. That's fine, thanks.
A question for you, Joyce. What anesthesia do you So today we pre-medicated with azithromycin and methadone prior to inducing with propofol in the MRI scanner. And then we maintained with isoflurane in oxygen. We don't have the option here for an air oxygen admixture, so just in 100% oxygen. We augmented the anaesthetic with additional analgesia by giving paracetamol this morning before the pre-medication, just orally, and a subcutaneous dose of paracetamol after we were induced and once we were stable and confident that we had good blood pressure.
These are frustrating because I find that often they don't come out in one piece like they would in mandibular salivary gland.
And at the time of surgical incision, we were 90 minutes after induction, 2 hours after pre-medication. There was a little bit of response to particularly the caudal aspect of the skin incision, and so at that point we gave additional alpha-2 agonist with medetomidine.
Of the mucocoele here. Amputated a bit of that. Can I get some 18 gauge wire, please? And a cerclage wire kit.
And then in addition to all those systemic drugs, we have also done a loco-regional technique whereby we have flooded the infraorbital canal, so the extension of the maxillary nerve, with bupivacaine, because the anatomy was disrupted where I'd normally do a maxillary nerve block. So we went at the rostral extent and just hoped for enough caudal spread to reach the pterygoid fossa by doing so, which should desensitise the deeper tissues, including around the sciatic itself, though it is unlikely to be effective for skin zygomatic arch. Pepe is asking, Charles, how do you distinguish glandular tissue from the rest?
Salivary gland tissue has a fairly characteristic appearance of kind of being multilobular and pale, kind of white. It can be tricky, and honestly, sometimes we don't know. Did we get the wire driver? We did. So I'm just getting some wire ready to drill some holes in the bone. See if that's going to be big enough. Yep. We're putting the bone back, yeah. And you don't absolutely have to put the bone back in, but if we can, and it's easy, we will. I'm just drilling holes in the bone.
Is there a risk of facial paralysis with this procedure?
So facial nerve, except for the branch that goes to the palpebral branches, that's the only bit of the facial nerve which is at risk, and it definitely is potentially at risk if you're not careful.
Does the size of this sialoceal increase that risk just because it's so large and the margins are broader?
I don't think so. Yeah, because all I'm doing, so question internally was, does the size of the mucocoele increase the risk? And I'm not dissecting any further than I normally would. And so that risk should not be increased. This wasn't a particularly easy one.
I don't believe there's a non-surgical option to resolve a sialoceal, is there?
I don't think that there's a non-surgical option. I mean, people have tried marsupializing and stuff like that, but generally that's going to result in recurrence.
Technical question. We can see your questions coming up on a screen behind the surgeons, which is why we read them out to Charles, because his back is to the tower.
What was the question?
The question is, how can you tell that we're asking questions?
Clairvoyant.
Where is the screen? I do like the idea, though, of special glasses that it comes up on.
Yeah?
Yeah.
Which, like Apple, what is it, Vision Pro?
You can get, yeah.
I could definitely, and have been looking at them, but I think the reviews are too mixed right now to justify getting a pair for $5,000 Australian.
One day we'll all have retinal implants.
Yeah, like on Black Mirror.
I look forward to the day of wireless anaesthesia, though. That's nice. Maybe one day.
I'm just kind of pre-placing my wires here. Now, which way did this go in? Should have checked that before. Yeah, that's it.
We've had a few questions come up rapid fire. So there was one about using loops, and Charles is not using loops in this surgery.
Normally I do.
There was another question about intracranial acetylcysteine injection as an adjunctive treatment, which I haven't heard of before.
I haven't heard of that either. That's mucomist, which is a mucolytic. Which way was? I think it was that way. Yeah.
There's a question about, is there a risk of damaging the ocular tissue whilst operating, and if so, what precautions are we taking?
Yes, there is definitely risk of damaging the ocular tissue, and you just have to be careful with the dissection.
We were also careful in the prep
Yeah.
And iodine was used for the final prep so that if there was inadvertent splash, it didn't traumatise the cornea. Oh, intracanicular, which with the questions coming up quickly, I misread as intracranial.
Canicular, I guess, would be inside the canal, the duct, but I have not heard of that as being an option.
There was also a question about what is the role of the veterinary nurse in this kind of procedure.
So the veterinary nurses are going to be doing patient care, passing the IV cannula. They're going to be doing the clip and the prep, assisting with the MRI. Often, when we don't have an anesthetist, they're doing the anesthetic. Post-op patient care, some of the client communications.
They scrub sometimes too, don't they?
And they
depending
scrub
on who
into
we have
surgery
available.
sometimes too, yeah. And I'm a big believer in just absolutely maximizing the amount of contribution that the nurses make, which makes my job so much easier.
And we're fortunate here that legislation facilitates that and supports our nurses in doing so, unlike some jurisdictions. I'm pretty sure those were all of the questions that came through.
I usually go through at the end
Okay.
and make sure that there's nothing I've missed. So this is a bit more of a hassle to replace this bone fragment than it sometimes is. We did put it in correctly.
Yeah, right way around.
Yeah.
We have a question about your platforms, Charles. Are you live on both VetDojo and VetAlign?
Yes, I am now live on both VetDojo and VetAlign. I got a new service that I pay about $300 or $400 a year for, and that allows me to live stream on both.
And another question about your technique. Is there a pro-con breakdown regarding the replacement of the zygomatic bone that you removed for access?
Is there a?
What are the pros or cons of replacing the zygomatic arches you're doing?
So I often don't replace it if I'm doing cancer surgery. The theory is that the reason why you want to replace it is because it's going to support the globe ventrally, and I would assume that in humans you could get like double vision if you did not replace the zygomatic arch, because the eye could potentially fall down ventrally a little bit, but in dogs we don't know if they have double vision or not. And I'm not going to put a drain in this because we've evacuated all of the saliva, and we shouldn't have any reason for more saliva to be formed, and we're not getting a lot of oozing or anything like that. That zygomatic arch is very firm, stable in there. Can I get some 2 OPDS, please?
We've had some feedback that one of your viewers has been asking questions on VetAlign, but I infer that we haven't seen them crop up on this platform.
Right, it should come up on both, but Can you click, please, on where it says veterinarian? Sorry, down here.
Oh, there?
Yep. And see if it... So none of the questions are coming up from... Okay, here we go.
Oh, quite a few.
All right, so go slide all the way back up to the top.
Can you please give your opinion on Stephonta in treating soft tissue sarcoma?
So first off, Stephonta is not labeled for soft tissue sarcomas. It's only labeled for mast cell tumors. Second, my opinion is that anything you can do with Stephonta, you can do better, more accurately, more elegantly, and with less patient morbidity with a sharp blade. So I am not a proponent at all of Stephonta. I imagine that there are some applications for things that we can't do with surgery, but I haven't found one yet. So I am not a believer in it.
We've got, what's the complaint Dr. Charles for his dog?
So this dog had a zygomatic salivary mucocoele characterized by exophthalmos. When they aspirated it, they found saliva.
Does it have the same clinical signs as retrobulbar abscess?
It probably would have similar clinical signs to retrobulbar abscess, except that it's not systemically unwell. So I imagine if you had a retrobulbar abscess, you'd feel pretty crappy, whereas these guys feel normal.
Is extubation better than removing it in one piece?
So removing it in one piece would be better. I just have never been able to identify it and remove it in one piece in the past, because there's always so much blood and saliva around that it's not like a mandibular salivary gland where you can identify the gland in one piece and remove it in block.
What's those white thick structures we see? This was a bit a while ago.
Yeah, so there's probably some salivary tissue that we were working on. There's some nerves in there. The infraorbital nerve was kind of right in the middle of the field.
And last of all, what is the risk to the facial nerve?
So the facial nerve comes in here and branches to the dorsal and ventral branches. They're actually palpebral nerves. And the ventral branch in this area was more at risk than the dorsal branch because I only went up even with the equator, or kind of the lateral canthus of the eyelid.
Just before we keep going with the questions, Charles, do we need any imaging post?
Post imaging?
You happy with that?
Yeah. So I'm just going to leave this with Jacob to do some intradermal sutures. Just make it look nice because it's on the face. And I'll come over and make sure
Plastic
there aren't any
surgeon,
questions.
Jacob.
These last two.
So there is a risk of a non-union of the zygomatic arch. If that did happen, I would just go in and remove that fragment because it's not really that important. Does our anesthetist use etomidate at all?
It's hard to get hold of here, and I rarely need that kind of cardiovascular stability at the trade-off for the adrenal axis, and so no, I normally would use other options, though I have used it in the past occasionally in cardiovascular procedures, but most of the time for cardiology I've got other choices that I can use.
I'm just going back and checking all of the previous questions. Making sure there's nothing that I haven't answered. I think that that's about it. So I'm going to go ahead and end the live stream at this point. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live.